We are now going to talk about Pseudomonas. So by this time we have covered the gram-negative, which include the diprococci. Uh, we saw that the diprococci had Neisseria gonorrhea and Moraxella, and then Neisseria meningitis. The coccobacilli had Haemophilus influenza, Vertigosis, Vascular, Brucella, so on. And then the bacilli came, in which we saw that they were either acted as non-fermenters or fermenters. So when we talk about the non-fermenters, we performed the oxidase test and saw that only the Pseudomonas was positive. Now we go ahead and talk about the Pseudomonas, right? So Pseudomonas is really important. It's a very uh, commonly tested bacterial pathogen when it comes to exams. Something I would want you to know when you talk about Pseudomonas is that it's known as the hospital survivor. Okay, so we call it the hospital survivor. Now, so this is basically what do we know about this? This is basically aeruginosa. You can remember it's aerobic, right? It's motile. It has a polar flagellum, right? It has this special flagellum which is polar. It is catalase positive. It's oxidase positive. That's important. It's a gram-negative raw, bacilli, and it's non-lactose fermenting. It's frequently found in water and has this fruity odor. It has this grape-like odor. Right? This is a very important um, clue on exam vignettes that it has this fruity grape-like odor. It's found in sinks, ventilators, catheters, burn units, contact lens solutions, basically these wet areas, hot tubs, it also causes these hot tub folliculitis and ICU settings. Right, so this is all the places that you find Pseudomonas existing in. Now, why is Pseudomonas so dangerous? I wanted to punch this here for you. Where is it found? It's found in sinks, ventilators, catheters, burn units, contact lens solutions, hot tubs and isocyanates, right? Okay. So back to our Pseudomonas part. Why is it so dangerous? Most bacteria cause disease because they invade. Pseudomonas causes disease because it has multiple weapons which act simultaneously. It has toxins, it has a biofilm formation, it also has antibiotic resistance, and it has the ability to survive almost anywhere. So that's why it becomes this major hospital pathogen. The hospitals hate it, right? They have a very love-hate relationship. Now, remember that the classic lab clue would be that Pseudomonas has this blue-green pigment. It's called the, here you can see this is the blue-green pigment. It's called the pyocyanin. So, and the pyoverdin. So, pyocyanin is basically the blue-green one, and pyoverdin is the yellow-green fluorescent pigment. If a question mentions blue-green pus, you remember Pseudomonas, right? And it also has a fruity grape smell. Right. The mechanism. Okay, so one clinical story to remember everything when it comes to Pseudomonas is that a patient will show up with cystic fibrosis and he's admitted to the ICU. He develops blue-green sputum with a grape-like odor. Culture shows an oxidase positive gram-negative rod that forms a mucoid biofilm. Diagnosis is Pseudomonas aeruginosa. Right. Now we'll come back to this vignette and let's just look at the organism itself. Now it has an exotoxin A. What does this exotoxin A basically do? It acts like a diphtheria toxin, which basically causes the ADP ribosylation of elongation factor 2, which basically stops protein synthesis and leads to cell death. Now, the diphtheria toxin and Pseudomonas toxin, both of them target the elongation factor 2. So it's exactly the same mechanism, and exam boards love this. The biofilm formation is also very important. So Pseudomonas forms this biofilm, and the biofilm basically is a slimy protective layer that is largely made from alginate. So you think about this large bacterial apartment complex, and inside this biofilm, antibiotics penetrate poorly, immune cells can't reach the bacteria wall, and the organism basically survives for months, right? The clinical importance when we talk about Pseudomonas, okay, so this is the biofilm, right? It's a slimy protective bacterial community made largely from alginate. Think about the bacterial apartment complex. Inside the biofilm, the antibiotics penetrate poorly. Immune cells can't reach the bacteria well, and the organism survives for months at a span. The most important association for cystic fibrosis is Pseudomonas infection. Basically, normal lungs clear the mucus, but a cystic fibrosis patient cannot clear his or her lung mucus that the same way, right? So Pseudomonas enters and makes this alginate biofilm. And this becomes impossible to eradicate because this progressive lung restriction. So an exam flu would give you a teenager with cystic fibrosis and a chronic lung infection, and then you'll see this blue-green sputum and you know that it's Pseudomonas. This biofilm forms on the Foley catheters, on central lines, on endotracheal tubes, and the result is basically persistent infection. It's also a very common burn wound infection, so it's very commonly seen on burn wounds, right? This is the classic question. The burn basically destroys the skin barrier, and Pseudomonas enters, and sepsis happens if it's untreated, right? So burn patients, it's very, very commonly seen in burn patients. The burn patient develops a fever that has a green wound discharge with sepsis, and you get this Pseudomonas, right? You also get hot tub folliculitis because Pseudomonas loves water. So the patient uses a hot tub and gets these pruritic papules or pustules on his body, and this is basically hot tub folliculitis. The eye infections are also very common. Contact lens wearers can develop this corneal ulcer or keratitis. You usually have a young person who uses contact lenses and gets this eye pain and red eye and photophobia. This is an ophthalmologic emergency. Permanent blindness can occur, right? And then we have something called as the eczema gangrenosum, which is basically when the bacteria invades the blood vessels. So necrotic skin lesions caused by the bloodstream spread of Pseudomonas is one of the most important systemic manifestations. The bacteria basically invades the blood vessels and causes tissue ischemia and vascular destruction, which basically causes the ischemia, which leads to necrosis. And then you have this black center, which has red surrounding skin. So remember that this appearance starts with a red lesion, which slowly can be seen having a black center, black necrotic center. This is seen as in neutropenic patients, in leukemic patients, in ICU patients, basically immunocompromised patients. Why is it seen in neutropenic patients? Why neutropenia? Because neutrophils are the major defense against Pseudomonas. When neutrophils disappear, the Pseudomonas spreads very, very rapidly. I'll show you this picture here. So can you see that it produces this black center with a red outside, right? Don't worry about this mucoid thing. It doesn't explain this thing here, right? It's just part of the explanation of the entire bacteria. So also antibiotic resistance is very important when we talk about this specific bacteria. It basically has a lot of things that protect it from the antibacteria. It has efflux pumps, which basically pumps the drugs out, right? It also has foreign mutations. Um, so we have these efflux pumps, which basically pump the drug out, so the drug can't affect the infection. Then it has these foreign mutations. This basically prevents entry of the drug. And then it has beta lactamases, which basically destroy antibiotics, and it has biofilms, which basically shields the bacteria, right? So we have these specific anti-Pseudomonas drugs, and that basically includes this carbapenem. So you remember campfire as this mnemonic to remember the drugs for Pseudomonas. Most importantly, the ones put on the exam are this piperacillin and ticarcillin, right? But we're going to study all of them. So carbapenems include the meropenem, imipenem, and aminoglycosides include the gentamicin, tobramycin, amikacin. Monobactams are like the aztreonam, polymyxins are like polymyxin B, colistin. Fluoroconolins include all this fluoxetine, levofloxacin, and then third and fourth generation ones. These are basically fourth generation ones are like the cefepime, ceftazidime, and then you have some extended spectrum penicillin, right? These include the piperacillin and also something tazobactam is very important here. And E you can also remember as end of story, right? So one clinical story that connects everything, we go back to our clinical story here. A patient with cystic fibrosis is admitted to the ICU. He develops blue-green sputum with a grape-like odor. Culture shows an oxidase, positive gram-negative rod that forms a mucoid biofilm. Diagnosis is Pseudomonas because blue-green pigment and grape-like smell and cystic fibrosis and biofilm leads to Pseudomonas until proven otherwise. Right, I'm going to stop the video here because it's getting too long.